So we'll be starting with the topic of acute kidney injury. So acute kidney injury, as you all know, is defined as a rapid deterioration of the renal function resulting in retention of nitrogenous waste and inability of the kidney to regulate fluid and electrolyte homeostasis. So there are certain risk factors for AKI, which includes younger age, sepsis, shock with multi-organ dysfunction and need for mechanical ventilation. So we have a categorization based on the severity of acute kidney injury. We have the refill criteria in 2000, which was given in 2002, the modified for pediatric age group pediatric refill, the AKIN classification in the 2007, and the KIDICO classification in 2012. So, on the basis of severity in the refill criteria, refill by the acronym, it says it's risk for renal dysfunction, it is injury to the kidney, it is failure of the kidney, and it is loss of the kidney function. E stands for end stage renal disease. Now the pediatric modification of the refill criteria, that is based on the formula, that is it is based on the estimated GFR. Estimated GFR is calculated by the Schwartz formula, in which we where K is our constant, which we multiply with the height and then we divide with the serum creatinine. It is K into height divided by the serum creatinine. So the value that we'll get is the estimated GFR for that age. And the value of K, which is the constant, is 0.3, 0.4, 0.5 and 0.7 according to the age group. So to explain this plainly, if the eGFR is decreased, that means that the kidney is not working properly, it is not generating the GFR that is required to excrete the waste. So it tells about the level, the extent of kidney injury. The lesser the GFR, the poorer the prognosis and higher is the stage of kidney injury. Now next we have is the AKIN classification. The AKIN classification uses the parameter of serum creatinine and urine output. It divides into 3 stages. In stage 1, the serum creatinine should increase more than 0.3 milligram per deciliter in 48 hours, or there should be increase in 1.5 to 2-fold from the baseline, or the urine output should be less than 0.5 ml per kg for more than 6 hours. So a serum creat and urine output. A serum creat that is increased more than 0.3 milligram per deciliter in the 48 hours, or there is increase in 1.5 to 2 folds from the baseline. A urine output that is less than 0.5 ml per kg for more than 6 hours is categorized in stage 1 of acute kidney injury according to the AKIN classification. In classification 2, there will be increase in 0.2 to 3 folds from the baseline in serum creatinine, and the urine output will be less than 0.5 ml per kg per hour for more than 12 hours. It was 6 hours initially, now it has become to 12 hours. In stage 3, the serum creatinine will increase by more than 3 folds from the baseline, or the total serum creatinine value becomes more than 4 milligram, or the urine output is less than 0.3 milligram ml per kg for 24 hours, or there is complete anuria. So 0.5 ml for 6 hours stage 1, 0.5 ml for 12 hours stage 2, and 0.3 ml for 24 hours, or there is complete absence of urine, that is anuria, then it is stage 3. Let's revise the serum creatinine again. If the increase in more than 1.5 to 2 folds, or the increase is more than 2 to 3 folds, or the increase is more than 3 folds, is divided as stage 1, 2, 3 respectively. So we have seen a refill criteria, a pediatric refill criteria, AKIN classification, the KIDICO classifications. Now let us see the possible sites that can be involved in acute kidney injury. So this is the Bowman's capsule, and this is the R tubule, PCT, DCT, and now this is a glomerulus that I'm showing. So if the presentation involves the glomerular injury, then it will present with hematuria, proteinuria, hypertension, and urinary cast. If the presentation involves tubular injury, so it will present with pH abnormality, electrolyte abnormalities, or if both are involved, then there'll be a mixed picture of glomerular and tubular injury. Now let us come to the classification of AKI. AKI can be pre-renal, renal, or post-renal. So let us try to understand the pre-renal cause of acute kidney injury. In pre-renal cause, there will be decrease in the effective circulating blood volume. So whenever there is decrease in the blood volume, there will be increase in the osmolarity that will be detected by the receptor. So we have the receptors in the macula densa also. So the macula densa will detect increase in osmolarity, decrease in circulating blood volume coming to the kidney. So it will release renin, and that renin, by conversion from angiotensinogen 1 to 2, it will form angiotensin 2, that will effectively stimulate the adrenal to produce the aldosterone, that will cause retention of sodium and excretion of the potassium, and there will also be increase in the blood volume because there will be retention of water. So this is what happens normally when the kidney fails to generate the effective volume by this mechanism. Also, there will be in prolonged hypoperfusion of the kidney that will lead to permanent damage. So a pre-renal cause can change to a renal cause if there is prolonged hypovolemia, and the cause of pre-renal is diarrhea and vomiting. So now let us come to the renal cause. In the renal cause, the disorder is characterized by renal parenchymal damage, which can be due to hypoperfusion, ischemia, or nephrotoxins. Hypoperfusion I just explained. So it can be due to sepsis if there is a profound sepsis in the body. It can be hemolytic uremic syndrome. It can be due to any toxins or a nephrotoxic drug that is causing that is damaging the kidney. So post-renal is easier to understand. Post-renal means there is obstruction to the flow of urine. Whenever there will be obstruction, there will be increase in the back pressure. That back pressure hampers the kidney. So if there is prolonged obstruction, there will be kidney deterioration in the kidney function eventually. And the causes include the posterior urethral valve and the PUJ obstruction with stones in the kidney or in the ureter. So, the clinical presentation of acute kidney injury, there can be history of vomiting, diarrhea, or blood loss. There may be features of dehydration and features of tachycardia, hypertension, pallor, and decreased urine output, all suggestive of hypovolemic shock leading to hypoperfusion of the kidney, and that is causing that is hampering the functioning of the kidney. Whenever there is a renal cause involved, so there'll be features of hematuria, edema, hypertension. All these are suggesting of glomerular etiology. There'll be history of dysentery, there'll be presentation of petechiae and pallor that will point towards HUS. If there is sudden dark red urine, pallor, and jaundice, then it's acute intravascular hemolysis. If there is rash with arthritis, there'll be SLE or HSP. And if there is history of exposure to nephrotoxic drug, or there can be fever, arthralgia, rash, and exposure to drugs like NSAID or antibiotics. Now the post-renal cause, there'll be history of interrupted urinary stream, and you can have a palpable bladder and a kidney which is suggestive of obstructive uropathy. You can have abdominal colic, hematuria, dysuria suggestive of urinary tract calculi. So the lab investigation that we'll be going for evaluation of acute kidney injury, you'll be needing serum creatinine, urea, electrolyte, CBC. urine analysis, microscopy, imaging studies, serological testing and early biomarkers, and renal biopsy. So in CBC, you will find anemia, which can be hemolytical as in cause of SLE. You can find leukopenia. You can find leukocytosis, thrombocytopenia. So these are the pointers that will help you clinch the diagnosis. You can have hyponatremia, which will be dilutional. You can have metabolic acidosis. You can get elevated blood urea nitrogen, creatinine, uric acid, potassium, and phosphate. And in urine analysis, you will find dysmorphic RBC cast, which is suggestive of glomerulonephritis. You can find WBC cast, suggestive of pyelonephritis. Blood with eosinophilia, suggestive of interstitial nephritis. Or you can find hyaline and granular urinary cast. Imaging study, you can get cardiomegaly or pulmonary congestion, suggestive of fluid overload. In renal ultrasound, you will get to know about the renal and bladder anatomy, if there is any obstruction to the blood flow. DMSA scan you can do, and you can do MCU renal Doppler or a CT MRI. So what are the indications of renal biopsy in case of acute kidney injury? If there is feature suggestive of systemic disease, if there is unremitting renal failure lasting longer than 2 to 3 weeks, or case of suspected AKI due to nephrotoxic drug. So concepts of biomarker. So biomarker are molecule which are released from the nephrons due to cellular insults. I'll be taking a separate session on biomarkers later. So we have few biomarkers like interleukin 18, neutrophilic gelatin associated lipocalcin, kidney injury molecule 1, and cystatin C. So now let us come to the general management of acute kidney injury. It's very important to understand. So I'll be covering the topic in terms of fluids, any withdrawal of drug, if there is any role of diuretic, vasopressors. Okay, so the general guidelines by the KDIGO 2012 says once the AKI is diagnosed, both urine output and creatinine is used as a measure of acute change in GFR. In any absence of any hemorrhagic shock, isotonic crystalloids are preferred over colloid as the initial management for expansion of the intravascular volume. In critically ill patient, insulin therapy should be targeted. Plasma glucose should be in the range of 110 and 149 milligram per deciliter. Diuretics are not recommended unless until there are features of volume overload. There is no role of dopamine in case low dose dopamine in case of acute kidney injury. So what are the complications of AKI and what are the management that is needed to be done? So one of the complication is hyperkalemia. A normal kidney excrete excess of potassium, but in case of acute kidney injury, there'll be hyperkalemia, which can be mild, moderate, and severe. So first and foremost, we need to stabilize the membrane as there is high susceptibility of arrhythmia in hyperkalemia. So we give calcium gluconate, which act as a membrane stabilizer. Then we need to lower the potassium concentration in the serum. So drugs that we have which causes transcellular shift are beta agonist and insulin and potassium binders that we can give. And mild metabolic acidosis does not require any treatment, but when there is severe metabolic acidosis with pH less than 7.15 or bicarb is less than 8 milliequivalent, then we treat with bicarb correction. Hypocalcemia is also a known complication of acute kidney injury. In hypocalcemia, what we give is we can give the correction orally if the child is asymptomatic. IV correction is only indicated in case of symptomatic patients. In for hyperphosphatemia, we are supposed to be giving a low phosphorus diet that is devoid of chocolates, milk products, and nuts, because they have high phosphate content. You can give a phosphate binder. Commonly available is Sevlamar. And hyponatremia is also a complication of AKI. It is most of the time it's dilutional, so restricting the fluid would help in normalizing it. But if the patient presents in seizures or the patient presents with lethargy, then it is suggestive of symptomatic hyponatremia. And if the serum sodium is less than 120 milliequivalent, then you need to treat it with 3% NS. So the nutrition. Nutrition in AKI is very important because AKI is associated with the catabolic state. So there'll be increased negative nitrogen balance. Enteral feeds are preferred over parenteral feeds, and a high biological value protein, low phosphate, low potassium diet should be used. And we give out age appropriate calories for the patients in AKI, and protein restriction should be avoided. You can give zero point 0.8 to 1 gram per kg per day of protein in AKI patient without dialysis, and 1 to 1.5 gram per kg per day proteins in patient with dialysis. Other supportive management include, for infections, we need to give antibiotics. Hypertension should be managed with antihypertensive. Anemia, if the hemoglobin is less than 7, we need to transfuse PRBC. And in neurological symptoms, headache, seizure, lethargy, confusion, benzodiazepines are the most effective. So that's all for this topic. Thank you so much.